talk, I invite Dr. M.V. Francis, Chief Consultant at Theresa Eye and Medical Center, Cherthala. He is the President-elect of Headache Society of India and reviewer for Annals of Indian Association of Neurology and free paper evaluator for Neurophthalmology section of All India Journal. Over to Francis, sir. His talk is on posterior reversible encephalopathy syndrome.
So, very good morning everyone, and thank you Dr. Arun. RPLS or PRESS, reversible posterior leukoencephalopathy syndrome or posterior reversible encephalopathy syndrome. Rare syndrome, but it can be a shocker for any of us on any day. It is not always posterior, not always in the parieto-occipital region, it can be anterior also. It is not always reversible. And leukoencephalopathy is white matter dysfunction, not always white matter. Gray matter also can get affected. So when do you suspect this syndrome? The predisposing factors. You remember TRAP or TRAP. Basically it is a trap. T means transplant, post-transplant patients, any organ transplantation, thrombocytopenic purpura, and tacrolimus like anti-immunosuppressive drugs. R is renal dysfunction, dialysis or nephritis. A means autoimmune disorders like SLE. And the most important is the B, blood pressure, acute rise in blood pressure. And also remember, P means preeclampsia, eclampsia. You know, the maximum cases, 90% of the cases are peripartum or postpartum. Now the symptomatology, how do they present to you? They can present with blurring of vision or scotoma or total blindness. So when they get blurring of vision, it is not the usual blurring that they get. Migraine patients with aura can get blurring and they can get it after delivery also, any time. So it must be a new onset blurring, new onset scotoma and a new onset headache. If they get headache in the past, this will be something new. That they tell you, this is not the usual headache that I get. And the next group of symptoms are not for you, seizure and mental state changes. And there are so many other symptoms which may not come to you. And this is the case, a typical case, 28-year-old female, postpartum day 2. Past history of migraine, but this time she started getting headache, which is a different type. And next day blurring, and by evening she was completely blind with mild confusion and disorientation, and BP was 190, 110. And clinically, you know, patient blind, doctor blind, something like retrobulbar neuritis, where minimum you get APD and color vision defect. Here there is nothing. So whenever you get pupil brisk, immediately focus on to the posterior visual pathway, the occipital lobes and visual cortices. Of course, psychogenic blindness can be an extremely rare differential, but you have to rule out RPLS or infarct first. You may get hypertensive retinopathy changes, grade 1 to grade 4. So you get this symptom in that predisposing stage, you always think of a stroke mimic. And this is the MRI, T2 and FLAIR. You can see the hyperdensity at the occipital lobes, visual cortices. T2 and FLAIR will show you this hyperdensity. And the classical diagnostic sequence is, you know, diffusion weighting and ADC map. Diffusion weighting on the right, you know, you can see again hyperdensity, and ADC map will be hypodense. Usually in infarct it will be hypodense, this will be hyperdense. So once you get that ADC map hyperdense, that is, you know, the vasogenic edema formation. That is the time you get this. Otherwise it will be cytotoxic edema and you get hypodensity. And these are, you know, cases of RPLS with differentials, including bilateral PCI infarcts. So 90% always postpartum. So always remember a postpartum patient, be very careful about a postpartum patient. And CT is not that inferior. You can get CT also positive in many cases. You can see the bilateral hypodensity in the occipital lobe. And DDs can be of any kind, like PCI infarct, cerebral amyloid angiopathy, hypoglycemia, posterior progressive multifocal leukoencephalopathy, demyelination, metabolic. So, if it is not fitting into the right predisposing factors, then you have to investigate it. You have to go for extensive investigation by neurologists and different other physicians and other specialities. And why posterior? Why it is always posterior or 95% posterior? There is something known as autoregulation. So this autoregulation controls the blood flow into the brain. So in the posterior part, parieto-occipital area, there are very few sympathetics. So, whenever there is a high spike in blood pressure, this autoregulation fails. And there is vasodilatation and exudation, oozing. That is the mechanism behind. Of course, there are different other mechanisms which are not very important. So, this vasogenic edema will subside if you treat these cases early. That is why awareness, early detection, and either treatment or referral. Thank you. Thank you very much.
Thank you, Francis sir.